So today I'd like to present treatment-induced neuroendocrine prostate cancer. So oh, how I can control the slide, sorry. Yeah. So this is the agenda for today's topics. So first of all, I want to review the current management option for and also new topics for neuroendocrine prostate cancer. And the second, I want to review the Dr. Zobedi's lab work. Maybe everybody knows Dr. Mina Zobedi, but she's one of the top researcher in neuroendocrine or lineage plasticity for prostate cancer field. So I want to share the findings from Zobedi's lab. And then the last, I will present one of my research work from Zobedi's lab. So I'd like to start from current management option. As you know, sorry. Can you see my arrow here? Yeah, it's better. Sorry. So as you know, the prostate cancer is the most common cause of cancer in men in the United States and Europe, and also in Japan as well. And then the second leading cause of death. And then, yeah, of course, all of you knows, the vast majority of prostate cancer patients present with adenocarcinoma, which is driven by androgen, which means the typically associated with high PSA. So this is why we could check the patient PSA and then proceed the next step. However, neuroendocrine prostate cancer is one of the aggressive variant form of prostate cancer, which shows low or no androgen receptor expression, and then sometimes gain of the neuroendocrine phenotype. Usually, de novo NEPC is relatively rare disease, so less than 2% of all prostate cancer. So we barely see the patient has de novo NEPC. However, in these days, we had a kind of very strong AR inhibitor treatment, so which induce NEPC development later stage of CRPC patient. So it used to report it as 15 to 20% of patients, but these days the possibility will be more than 40%-ish. So the current clinical management option for diagnosis based on NCC and guideline, small cell / neuroendocrine prostate cancer should be considered patient with disease but no longer respond to ADT. So which means they're relatively rare disease but their PSA is still low. However, they have large metastatic burden or vesical disease. And then currently they require a biopsy to confirm NEPC. But we could imagine most of the case, the patient has bone metastasis. It's very hard and painful for biopsy. So at this stage, the confirmed NEPC is very, very, the challenging situation. So what's the treatment option for NEPC? So again, NCC guideline kind of recommend platinum-based chemotherapy for NEPC patient, which means combination with carboplatin plus etoposide, or if they have mixed cancer with adenocarcinoma, patient will receive taxane as well. However, the response rate of this treatment is really, really unfavorable, and also their prognosis are very poor. So median PFS will be 2 to 6 months, and then overall survival still less than 1 year. So I want to review 2 phase 2 clinical trial for small cell / neuroendocrine prostate cancer patient. So this is a clinical trial from 2002, more than 20 years ago. So they try to do the the combination of doxorubicin and etoposide and cisplatin. And then, so the response rate is not great. And also they have really they have really heavy adverse event from this treatment. So even 3 out of 38 patients died of toxicity. And then again, the median time of PFS will be just 5.8 months, and OS is 10.5 months. So that's why they conclude they do not recommend to this regimen for neuroendocrine or small cell carcinoma of prostate. And then 10 years later, this is a phase 2 clinical again, 2011. This time, they try to do the combination with carboplatin and etoposide for the patient which has MCRPC with high chromogranin A or NEPC, which are neuroendocrine prostate cancer marker. And then it's a very similar result from the last time. So, they have really, really severe adverse event. And then, unfortunately, one of them has a toxicity-related death. So that's why, they conclude, it's unfavorable result. So they won't continue this treatment anymore. So in summary, even though NCC and guideline recommend the platinum-based chemotherapy, still this treatment is still challenging. And then in reality, it's very hard disease to treat. So what's the new topics for this neuroendocrine prostate cancer will be? As I mentioned, to confirm neuroendocrine prostate cancer is based on biopsy. However, biopsy itself is really harmful and painful. So that's why they are thinking about a different approach. So recently, I think the Dr. Black also tried to figure out bladder cancer cell-free DNA. But this publication shows this is from serum cell-free DNA. They check the methylation of DNA, which represent the kind of mimicking RNA sequence or expression of gene. And then they divided the adenocarcinoma versus neuroendocrine prostate cancer. And then they figured out DMR, which means differentially methylated DNA lesion. And then they will make the signature score. And then based on the signature score, they could pick up the patient who has NEPC. So this is a liquid biopsy. So the alternative way to detect the neuroendocrine prostate cancer. Another approach or another topics will be DLL3. So recently we are getting used to PSMA PET scan for adenocarcinoma of prostate. So the same as PSMA PET scan for adenocarcinoma, we will have DLL3. DLL3 is delta ligand 3, so which is highly expressed in the membrane of NEPC. So that exactly same as PSMA PET scan, you can see if we inject H660 cell line, this is a de novo neuroendocrine cell line, and then here the LN cap here, and then you can see PSMA PET scan shows LN cap, and then this DLL3 PET scan shows NEPC tumor, but not adenocarcinoma. So, which means we could use DLL3 as a detection of the location of metastasis or recurrence of neuroendocrine prostate cancer using this method. And also the same as PSMA. Recently, we use a PSMA as treatment transporter. So the same as PSMA, they could use DLL3. So they will combine antibody, the one side connect to T cell, one side attached to the DLL3 on the neuroendocrine prostate cancer or neuroendocrine cancer. And then they will cause immunoreaction. It will kill the cell. So this one is already done for phase 2 trial in small cell lung cancer patient. And then they are open for phase 3 trial for small cell lung cancer. And then this one is from Vancouver Prostate Center. And then they inject high DLL3 PDX model. And then they treat with this drug, which shows really good response here. And then even in the patient after this, so AMG 757 is exactly same this drug, so which shows relatively good response. So based on the calculations, they have the PR, partial response of disease. So again, so in conclusion, so NEPC patient, treatment of NEPC is still challenging, but we have some new technology, DLL3, and also for detection, we have liquid biopsy using cell-free DNA. However, the point would be, the most of these clinical trial was based on de novo cancer patients. So I'd like to know why ADT or ALPI induced NEPC or small cell lung cancer phenotype. So to understand the point, we could find a new approach for the treatment. So as I said, Dr. Zoe Bailey is a really, really famous researcher in neuroendocrine prostate cancer field. So I joined the lab 4 years ago, and then I involved in some research work. So again, so this is a prostate cancer, the time course. So start from low PSA, and then at some point the patient has metastasis, his PSA is going up, and then they will have hormone therapy here. And then his PSA going down. However, after some sort of time, they will have castration resistance, and then they will have ALPI. So at that time, they had an enzalutamide, but these days we have more options, apalutamide and darolutamide. And then after ALPI, usually the most of the patient regrows the tumor with high PSA. However, some patient has progress of tumor, however, their PSA remain low. So the proportion of this patient used to be, less than 20%-ish, but these days, more than 40% they reported. And then our idea would be, we are start from adenocarcinoma, and then we somehow end up with small cell cancer. But we will have intermediate stage here, and then our idea could be, maybe this would be reversible. And then if we reversible, we will go back to adenocarcinoma-like phenotype, and then they will have response for ALPI again. So this is one of the summary figure. So which induce, or what is a master regulator for lineage plasticity, means transliferation to NEPC or other phenotype. So again, start from CSPC, and then castration cause CLPC adeno. And then from here to here, they have bunch of transcription factor or other factor to regulate the lineage plasticity. And then Dr. Zobei's lab mainly focusing on these three, not only, but mainly focusing on these three genes and protein. And then I will review, or I will discuss about these topics. So this is a 2017 article from Dr. Zobei's lab. And then this is focusing on BRN2. This is encoded by PU3F2. So they found this BRN2 as a AR response gene and also major driver of NEPC. So first of all, they developed the neuroendocrine prostate cancer model. So start from LNCAP. LNCAP is a very, very well-known adenocarcinoma cell line. First of all, they will make the castration treatment, the LNCAP, we call 16D. And then they did a xenograft to the mouse, and then they treated with enzalutamide. And then at some point, they will increase the size and volume of tumor, but some mice has relatively low PSA, even though they have very high tumor burden. Then most of the case, they are catching up the volume and also PSA is going up. So they compare these two two different group and then to find out what's the difference. So compared to CRPC cell line and this 42D enzalutamide resistant cell line, which means the PSA low but enzalutamide resistant cell line shows high NEPC marker. So that's why we thought, so this cell line represents NEPC phenotype. And then one of the top hit gene was BRN2. So BRN2 expression is high in NEPC cell line. So 42E, 42F, which is we derived the cell line, and also de novo NEPC cell line. And then this BRN2 expression is very high in human prostate cancer tissue as well. And then more importantly, if we knock down this BRN2 gene, their tumor marker is also going down, which means, the BRN2 is just not only the marker of NEPC, but also, which kind of driver for NEPC. And then if we knock down BRN2, the proliferation is going down, and also the knockdown of BRN2 in 42D cell line decreased the PDX tumor volume. And then more interestingly, BRN2 inhibitor decreased the tumor volume in de novo NEPC cell line NCI H660 and also treatment-induced NEPC cell line 42D. So we checked the tissue from this NEPC cell line treated by BRN2 inhibitor. So we can see, of course, BRN2 going down as well, but also SOX2 going down and also Ki67 going down as well. So this is one of the promising treatment option. And then another publication from Zobei's lab would be we are focusing on EZH2. So I joined the lab at that time, so I involved in this publication, and also interestingly, Sahil is here. So he was also one of the members with Zobei's lab. Anyway, so as I mentioned, this 42D cell line is derived from 16D cell line, which means adenocarcinoma. So, but the 42D will be intermediate situation of, the adenocarcinoma and NEPC. So, and then 42D still highly express AR. So then our question will be, AR still has some role of differentiation or not? And then we compare the AR ChIP-seq. So I believe not of you guys know the ChIP-seq, but I just quickly mentioned about ChIP-seq. ChIP-seq will be, checks the binding site of mainly transcriptional factor or checks a histone modification. So we pick up so in this case, we pick up AR antibody and then we pull down AR antibody with DNA and then we sequence the DNA, which means we could see where the binding site of AR. And then interestingly, 16D, this one has high PSA, high AR, which shows binding site like this. And interestingly, 42D has more binding site, which means AR used to be bind somewhere. And then after enzalutamide treatment, which is an AR inhibitor, however, they will switch the binding site more, they will gain more binding site here. And then what we did will be, which is a binding site shows. So we check the binding site and then we annotate the target gene from binding site. And then we check what kind of gene set enriched from the binding site. I mean the target gene. So interestingly, the target gene of AR still have neuroendocrine differentiation or neurogenesis, which means this new gain binding site is really somehow they induce a neuroendocrine phenotype. So AR used to be, the classically AR thinking about the more luminal phenotype, let's say high PSA or high KLK3, the NKX 3.1. However, after enzalutamide treatment, AR still have some function which induce neuroendocrine phenotype. So the next step will be what's a partner or who changed the location of AR. So we did RIME. So I don't want to, dig into the method of RIME, but the purpose of this one will be try to find the partner of binding. So compared to 16D, CRPC situation, this NEPC situation has another partner rather than FOXA1. And then we figured out EZ82 will be the one of the new partner in NEPC situation. So we can see, so this is the same as the last slide. And then EZH2 ChIP-seq shows very similar binding character with AR binding in 42D, which suggests if we treat it with enzalutamide, they will gain the new binding site with EZH2. So if we treated the cell line with EZH2, so this one already have enzalutamide resistant. However, if we treat it with EZH2 inhibitor, they will decrease the proliferation, which suggests, if we treat it with EZH2 inhibitor, we could push back to the adenocarcinoma-like phenotype, and then they will have response of enzalutamide again. So this is an unpublished data from GANS trial. So maybe you're familiar with GANS trial. GANS trial is the patient has high-risk disease, high-risk prostate cancer, and then they will receive at least apalutamide plus ADT before surgery as a neoadjuvant setting. And then, meanwhile, we check the DNA. If they have any mutation in DNA, we will add another drug as well. And then this is a preliminary data from GAN trial. And then which shows, after treatment, they have this EZH2 signature going up. So this signature from this paper, and then based on these findings, we will add another arm for GAN trial, which has EZH2 inhibitor. So which means EZH2 inhibitor will be another treatment option for NEPC, or they might have NEPC in the future patient. And then the last paper will be the 2022. We are also focusing on ASCL1. So for ASCL1 is also one of the really well-known key factor for NEPC development. So this time we are doing ataxic. So again, I don't want to dig into the ataxic itself, but this technology would detect which is an open chromatin. Open chromatin will be more accessible, and then we could imagine more high expression of gene. Anyway, we compare the 16D CLPC cell line treated with enzalutamide 3 days and 10 days, and then we compare the accessibility of DNA. And then we end up with ASCL1 is the most so the most accessible lesion has the ASCL1 motif in the most. So which means ASCL1 somehow bind to the open chromatin in the after enzalutamide treatment. And then if we overexpress ASCL1, which shows high NEPC marker. So, and also if we knock down ASCL1, which shows decrease of NEPC marker, which means the same as BRN2, ASCL1 is one of the driver for a neuroendocrine phenotype. And then, interestingly, if we lose ASCL1, so if we knock down ASCL1 in 42D, 42D looks like going back towards 16D. So which means if we treat it with ASCL1 inhibitor, we could push back to the patient or cancer towards adenocarcinoma. So in summary, so ASCL1, BRN2, EZH2, this kind of target gene will be, they will modify the DNA going towards NEPC phenotype. However, if we target this gene, we could push back to the adenocarcinoma. So in that case, they will still have response for ALPI. And then finally, I will share my research work in Zobeli's lab. So as you know, adenocarcinoma has a really good serum marker, PSA. So because, the adenocarcinoma only AR-driven, so other words, AR is a really, really strong driver for adenocarcinoma. So that's why PSA covered all adenocarcinoma patients. So we could say if the patient has high PSA, we could imagine they have high burden of adenocarcinoma. However, NEPC, as I said, they have a lot of driver gene. And then in reality, even in the NEPC, they have some variety. It's driven by ASCL1. The patient has driven by NMIC, driven by BRN2. So they are different RNA expression. So it's very hard to pick up the patient using only one tumor marker. And then chromogranin A and NACs are mostly driven by ASCO1. So if we have the patient driven by BRN2, sometimes we will miss the patient only using chromogranin A or NSE. So that's why I want to focusing on BRN2 induced serum marker. So I start from BRN2 ChIP-seq data. So again, so this is a sequence data. Then we can see the sharp peak here. So this peak means BRN2 protein bind to the DNA. And then you can see the peak here. And then this is a consistent in NEPC cell line and also lung cancer cell line. So we pick up this shared peak and then we try to find the target gene from this shared gene. And then, the serum marker should be secreted in blood. So that's why we filter the gene with human protein atlas. This is a kind of list of secreted protein. And then we combine the data and then we end up with 51 genes, which means they have relatively nice peak around the gene and also they are secreted protein. And then our purpose will be we want to see the patient has high BRN2. So we compare the all 51 genes versus BRN2 expression in the patient cohort. And then we combine the data and then we figure out NPTX1 is one of the highest correlation has with BRN2. And then interestingly, so non-NE marker, of course, they sort of correlate with BRN2 expression. I mean, both the NEPC patient has relatively high BRN2 and also relatively high NAC and chromogranin A, but the correlation is not very high compared to NPTX1. So that's why we could say, chromogranin A and NAC is still useful, but the NPTX1 is more specific for BRN2 expression. And then we check the expression of NPTX1 in PDX model and also study model. So this PDX model derived from the YZ lab in Vancouver Prostate Center. So they xenographed surgical specimen, and then after castration, of course, their PSA going down like this. And then interestingly, only this model, they have high NEPC marker after castration. And then the BRN2 is also going up after castration, and then NPTX1 is going up as well. So, which means it's kind of parallel for BRN2 expression, and also they losing PSA, they gain NPTX1. And then we can see similar tendency. This Jorana trial will be they check the neoadjuvant treated prostate cancer specimen. I mean, before and pre-neoadjuvant with enzalutamide, they sequenced their tumor, patient tumor, and then compare the gene expression. So we are using their data and then compare the PSA and NPTX1. So we could imagine this is the kind of positive marker for experiment itself. So after treatment, we could see the decrease of PSA. Of course, they treated by enzalutamide. And then interestingly, after just 3 months treatment of enzalutamide and ADT, they increase NPTX1. So which means we could detect very early stage of NEPC differentiation. And then we confirmed our finding using single-cell RNA-seq data. So I'm not sure you guys are familiar with RNA-seq, single-cell RNA-seq data, but basically they are kind of very, very tiny dot here. The one dot means one cell. And then we could see the expression of each dot. And then, yeah, you can see AS01 has very high expression in this cluster. And then this cluster has from different patient, which means this patient has relatively high AS01. And on the other hand, BRN2 highly express this patient and this patient, not these two. So we could say this patient will be driven by ASL1 and also BRN2, but this patient driven by mainly BRN2. And then interestingly, NPTX1 expression high in these two patients, which means, again, this is a confirmation of our findings. NPTX1 represent BRN2 expression. And then more interestingly, this is a chromogranin A expression. As I mentioned, chromogranin A mainly derived by ASCO1. So that's why this cluster, this patient has high chromogranin A, but this patient has no expression of chromogranin A. So which means we just monitor chromogranin A, we will miss the patient potentially has a development of neuroendocrine prostate cancer. So the next step will be, in reality, how we could detect this NPTX protein in serum. So I started from the culture media of NCI 8660. We already know this cell line has high expression of NPTX1. So I culture this cell and then I filter the media, which means there's no cell in this media. And then we check the Western blot. So Western blot means, detection of protein. So in cell lysate, of course, they have high NPTX1 expression and also BRN2 expression. So which means the BRN2 usually in your nucleus. So it will show up in cell lysate, but it shouldn't show up in media. However, we could detect relatively good amount of NPTX1 in concentrated media. So which means, NPTX1, yes, it is secreted in culture media. And then I try to, the Western blot require a lot of amount of protein. So in reality, from human sample, especially here, patient serum, we cannot do that much of protein. So I try to find out the relatively high sensitivity detection way. So we have RPlex assay. This is using the same idea of ELISA. So using antibiotics reaction. However, they are using more high sensitivity with electricity. So we could detect NPTX1 in cultured media as well. So, and then, we have confidence we could detect NPTX1 concentration. So the next step will be, can we detect NPTX1 in serum? So I use the xenograft model. So we inject this de novo NEPC cell line to the mouse, and then we collect the serum. And then we check the NPTX1 expression, the concentration. So for this model, they have, exactly same expression level of NPTX1 in tumor. For sure, they injected monoclonal cell line. And then we measure the size of tumor and then compare the NPTX1 serum level. So you can see if we increase the tumor volume, it's almost parallel, highly correlated with NPTX1 concentration. So which means, we could detect NPTX1 in serum, and also we could examine the tumor site using NPTX1 concentration. So the next step will be the PDX model. If the tumor has different expression level of NPTX1, can we still determine the expression level of NPTX1 using serum? So in conclusion, if the tumor has relatively high expression of NPTX1 in RNA, they could have high concentration of NPTX1 in serum. So which means if they have only one tumor, even the tumor has low, high NPTX1 expression, we could correctly detect NPTX1 expression. And then finally, we check the human sample. So this one is using from University of Washington autopsy cohort. So in their cohort, so they are from this sample from the patient died by prostate cancer, and they pick up some tumor, and then they already done RNA-seq data. So we could compare RNA-seq data versus serum NPTX1 concentration. So, this one is more complicated situation compared to this model, since they have multiple tumor. Maybe this one has very high NPTX1 expression, but they didn't pick up the sample from this patient. So it's very hard to confirm the result, but we can see nice tendency. So if the patient has relatively high NPTX1 expression tumor, so they have relatively high concentration of NPTX1. So in conclusion, start from TIP-seq data to the patient, we could find NPTX1 will be the really good marker for BRN2-driven NEPC, and then we confirm we could detect NPTX1 from serum from patient serum. So I could imagine, of course, NPTX1 is not absolute tumor marker of NEPC. However, combination with chromogranin A and NPTX and NAC, we won't miss the NEPC patient from treated with enzalutamide or ARPI. So this would be help us for clinical setting. So that's all from my presentation. Sorry for I put a lot of information, so not very organized, but hopefully you enjoy my presentation. So do you have any question?